Hi, everyone. We want to welcome you to another episode of the Sarcoma Sisters. I know you haven't heard from us in a while, so we're really happy to be back. And we have on today Dr. Suzanne George, who is a medical oncologist and the director of clinical research of sarcoma at Dana-Farber Cancer Institute, and also an associate professor at Harvard. And today we're going to focus on leiomyosarcoma. So welcome, Dr. George. We're very happy to have you today.
Oh, thank you so much for having me. I really appreciate the opportunity to be here with you.
Thanks. And I think to kick us off, actually, we usually try to get to know just our guests a little bit as well. So if you want to just tell us a little bit about your story, what got you into oncology and then specifically sarcoma?
Oh, sure. So it is a good question. When I was in medical school, I learned that I really enjoyed taking care of patients, and I really appreciated the long-term relationships with people. And because of that, when I was starting to think about what I might want to specialize in, I was looking at specialties that would allow that opportunity for relationship building over time. But what I also learned was that I am the kind of person that prefers to be a bit more focused in my disease areas. And I have so much admiration and really awe for primary care and for family practitioners, of which many of my dearest friends are in those fields. But I knew that for me, I wanted to be a bit more focused. And I wanted a lane that included a translational research component where you could really start to think about how you bring the science into the clinic and back again. And all of those things really brought me towards oncology. So that's how I ended up in oncology generally. I also was really fortunate after I finished my oncology fellowship. When I was looking for jobs, I was looking at jobs that would really, again, allow me a clinical component of my work, but also a translational and research component. And at that time, I have to be honest, when I was a fellow, I saw one sarcoma patient in my 3 years of fellowship. But there was a job opportunity available at the Dana-Farber Cancer Institute in the adult side. I'm an adult medical oncologist. And this was in the year 2000. And at that time, one of my mentors in fellowship had said, you should talk to this guy. It was a friend of mine. His name's George Dimitri. He's the head of the sarcoma program at Dana-Farber. He said that there's the next big drug is coming and he's going to get really busy all of a sudden and he needs help. And to me, I thought, how can you make a whole career in sarcoma? It's so rare. I've only seen one of them. And but I went over to Dana-Farber. I met with Dr. Dimitri. And that moment was really when they had just started to use imatinib or Gleevec in gastrointestinal stromal tumor GIST. And that was the first application of a targeted therapy in solid tumor oncology. And the response rates, it's absolutely changed and revolutionized how we treat that disease. So I was super lucky to really connect with a wonderful program at a time when the entire landscape of clinical research and clinical trials in sarcoma was changing and really bringing new therapies to patients. So I took the job and I was really busy clinically, and then have grown my own sort of research practice and research portfolio over time, working part of a really great team.
That is such an amazing story. And that's so great. And of course, Wendy and I definitely know Dr. Dimitri, and the sarcoma is such a close-knit community. Yeah. And I think that's so great. And I think, and sarcoma just gives you that opportunity, like you said, really the translational component too. It's funny, I still remember I was working as a medical assistant because I knew I wanted to go to medical school, and I was drawing blood for a medical oncologist who had her own private practice. So I would just draw her patient's blood, and she gave me an article, I still remember, on Gleevec, and she was like, this drug is going to change everything.
Yeah. It's amazing. I mean, it really has for the diseases. And I think, for I don't know if you guys have talked about GIST before, it's
no.
most gastrointestinal stromal tumor or GIST certainly that occurs in adults is a disease that's driven by gain of function mutations in this gene called KIT. And Gleevec, for there may be folks that aren't familiar, is a targeted therapy that works to block activated KIT, and it really shuts off the tumor very dramatically. And 80% of people will benefit, and for at least some period of time, and it's really, really remarkable. And so it really did start the paradigm of targeted therapies in tumors that have a single driver. And that's what GIST has always been a paradigm for. In sarcomas, though, as you know, not all sarcomas have a single driver to target. And that's where things can be much more complicated as we start thinking about other diseases and how we need to think about other ways to try to take advantage of the biologic vulnerabilities in a way that we can improve therapeutic outcomes. So that's I think what a lot of our teams have been doing over time.
Yeah, it's so interesting. You're did we do another adult? So we haven't done a almost purely adult sarcoma. We've done ones that have crossed that AYA range.
Mm-hmm.
Funny, I've only ever had one GIST in my life. So not even in fellowship, just in my whole career. But we, as pediatric oncologists, we focus a lot on the things that we know and that we're comfortable with and that we talk about a lot, but things that we haven't touched on. And one of our reasons for wanting to chat with you today was about things that we don't know a lot about in the sarcoma world. And, talking about Gleevec and GIST and all of those things. And I learned a lot about GIST when this patient came through a couple of years ago with the help of my adult counterparts here, no doubt.
Mm-hmm.
And, that targeted precision medicine is the dream of what every physician and every patient wants. And so one of the things that Lisa and I wanted to talk to you about today is we could do a whole different podcast on GIST and the different mutations and all of that stuff and how to treat that based on location and mutations and whatnot. But another thing that we want to chat with you about is leiomyosarcoma, which I know almost zero about. I did a little bit of Google research in preparation for chatting with you today. But can you talk to us about that? And maybe we'll reschedule a GIST conversation because I think that's just fascinating too. But we have a little ulterior motive on the leiomyosarcoma talk. Yeah. What is leiomyosarcoma, and is there something like Gleevec for it?
Yeah, no, it's a really good question. So leiomyosarcoma is a subtype, a type of sarcoma. It occurs primarily in adults. It is a soft tissue sarcoma, and it can start really in almost any part of the body. The most common locations are actually in the uterus. So uterine leiomyosarcoma is one of the most common primary sites of this very rare tumor. We also see leiomyosarcomas of the retroperitoneum, so the back compartment of the abdomen. And sometimes they start in association with the large blood vessels. So we might see a leiomyosarcoma associated with the inferior vena cava, the IVC, with a large blood vessel in the pelvis, sometimes a large blood vessel in the chest. And you can also see leiomyosarcomas in the soft tissues of an extremity, as one might see more typical soft tissue sarcomas of the thigh. But again, you can see them they can originate almost anywhere. And one of the biggest challenges is exactly that challenge, which is that there is not a single targetable driver in leiomyosarcoma, at least not that we understand as of now. And it makes it a very different biologic entity when one thinks about therapeutics than something like GIST.
Yeah, I think that is, I think probably much like you, I have this conversation, over and over in the clinic of, we hear things like Gleevec for GIST or Gleevec for, other diseases that are not in the sarcoma world. And we kind of hear these miracle stories, and they are sort of miracle drugs for us. And everybody wants that thing. And it's just so disappointing when we don't have that to offer to patients. And we haven't quite cracked the code on leiomyosarcoma or other things. And it's just so frustrating as a physician. And I'm sure it's even more frustrating as a patient that we don't have that. So if we don't have that targeted agent, is leiomyosarcoma treated like other soft tissue sarcomas with neoadjuvant therapy, resection, et cetera? Can you kind of just generally walk us through what treatment looks like?
Yeah, so the primary treatment is just structured very similar to other soft tissue sarcomas. So and it depends a lot on the primary presentation. So if leiomyosarcoma presents as an isolated primary site, so just in one place, then the primary management is local therapy typically. And what do I mean by that? I mean surgery and typically radiation. Depending in part on the size and the grade and the location, but typically it's surgery and radiation for localized disease. There may be a role for using chemotherapy either before or after surgery, but I would say in the adult space, that's a bit more controversial. Certainly consensus is surgery, radiation, maybe not chemo, depending on some of the subtleties of the individual case. And then, the hope is that with that approach of local therapy, the hope is that then that's our curative intent. That's when we hope that we can cure people. The challenge, of course, is that the recurrence rate, that the disease can recur. And if it recurs, whether it be local or distant, so local recurrence means it comes back in the same place, or a distant recurrence, meaning metastatic disease to a new part of the body, that's a much more challenging situation. And one that we often don't think of as a curable situation, but one that we think can be a treatable situation by using the tools that we might have in the toolbox. And what I mean by that is most of the time, if we're talking about multiple sites of recurrence, then we usually use chemotherapy. Occasionally, if there's only one or two sites that have come back, and there may be a reasonable, what we call it, the disease-free interval, so the time between the primary site and the recurrence is long, and one can discuss what long means, but is sort of longer, then we might consider surgery and or radiation for what we call, what's called oligometastatic disease. So I think the principles of leiomyosarcoma management are pretty similar to other types of soft tissue sarcoma. But we know we need to continue to learn about the disease, and we need to continue to do better, frankly.
And
Oh, go ahead, Lisa.
Oh, I was just going to say, what is the percentage of patients who their tumor will come back if it's just a localized tumor that was resected and then had radiation?
Yeah, so it depends a little bit on the location, actually. So tumors in the retroperitoneum, for example, have a higher risk for recurrence. And so the aspects of the tumor that influence recurrence are size, grade, and likely location, because the location can impact the ability to get negative margins at the time of surgery as well. So tumors that are larger, that are in challenging parts of the body and higher grade will be at higher risk to come back. Tumors that are smaller and are more easily resectable and lower risk will be at lower risk to come back. I do think that one particular unique component about leiomyosarcoma are the uterine tumors. So uterine leiomyosarcoma, as I said, it's one of the most common sites of this rare tumor. And it's important to note that, the vast majority of patients that these tumors are very, very uncommon when thinking about the vast majority of uterine cancers, for example. But when you go the other way and you think about leiomyosarcoma, you most commonly might see it in the uterus. But the primary uterine tumors are challenging because it's very difficult to diagnose them preoperatively, and they frequently can look like they occur in the muscle layer, what's called the myometrium, the muscle layer of the uterus, which is the same part of the uterus where benign fibroids occur. And benign fibroids are just really, really, really common. So most of the time, if one sees a mass in that location, it absolutely will be a benign fibroid. But rarely, very rarely, it could be, there could have some malignant components to it. And so the way that those tumors are removed is typically with hysterectomy, so intact hysterectomy, as opposed to trying to take out the tumor and leave the organ behind. It all needs to come out together to get the best outcomes long term.
Speaking of hysterectomies, which is the complete removal of the uterus and usually the fallopian tubes attached to it. What is the most common age range where you see leiomyosarcoma, and particularly uterine, because there's obviously impacts on, fertility and things like that. And so is this something that happens in younger women or older women?
It usually happens in older women. So if one looks at larger cohort series, the median age maybe in the people's in their 50s and 60s, some of these groups of people can have a little bit of bias to them, meaning that if you're looking just at the number of, for example, if you were to just look at the cases that came to Dana-Farber, the average age of those cases would probably be younger, because younger people tend to travel more and seek out second opinions. They may have more flexibility, etc. But generally, we think about it in women that are in the postmenopausal age range. With that said, we certainly, again, in our very highly high referral bias, lots of people that travel to us may be younger, I mean, in their 40s. Sometimes even younger, but it certainly is a disease of adulthood, and typically in sort of the middle to slightly older adulthood age.
And the reason I bring that up is kind of going back to your comment that uterine fibroids, benign tumors are very common. And those are very commonly seen in younger women also. And so sometimes as people are getting diagnosed with things, particularly in this kind of young adulthood range, people start to worry, like, could it be something else? What do I need to worry about? And so that was kind of like where that conversation was coming from. If I'm like a 27-year-old who's been diagnosed with fibroids, do I really need to be worried that something else could be going on? And the answer, of course, we always know is nothing is 100%, but just kind of looking at the norms of the population of who gets what. It's like you said, common things being common, is probably going to be a fibroid in somebody who's younger in their fertility.
Oh, for sure. Absolutely. Yes. Yeah. I think where things get a little bit, in all cases, it's almost always a fibroid, just based on odds. But one of the things that we're trying to do in an ongoing research project that's actually connected to the Count Me In project that we'll be talking about a little bit is we're trying to see if we can develop a system where using imaging, so specifically MRIs, can distinguish or increase the likelihood of being able to distinguish benign versus malignant uterine primary myometrial tumor, so fibroid versus sarcoma. It's challenging. We published a paper on this a number of years ago where we collaborated with our radiologists, and we did sort of what we call a case control study where we had some women with fibroids and some women with sarcoma, and they basically developed a risk scoring system to give a sense of how you can separate out the two. And as part of a new research project, we'll actually be reaching directly out to women who have had an MRI prior to a hysterectomy and ultimately found to have a sarcoma, in order to use those images as a further validation set of this potential, what would be considered a research or investigational model, to see if we can help improve the detection of these very rare tumors.
Yeah, that is some, this kind of radiomics, artificial intelligence learning for radiology, that sort of thing, something that I've thought quite a bit about for other things, because lung nodules plague my existence. But this is like a perfect disease for that. Get an AI learning system for trying to separate out benign from malignant, because there's huge ramifications for that. So that's super cool. I think so. I don't mean to interrupt. I don't want to forget to just mention, because okay.
The thing that makes, so we agree, we think that this is really important, and there's other groups that are thinking about this too. I think one of the biggest barriers to being able to successfully do this is actually access to the images, because it's such a rare tumor, and sometimes, oftentimes if women are having a preoperative MRI, it's not necessarily at the place that they end up getting their cancer care. So there's a lot of barriers to try to pull things together. So part of what we're doing through the Count Me In project, if it's okay, I can mention,
Yeah,
if I
please.
can mention that, is the Count Me In project is a project that is, Count Me In is an overarching project that allows the opportunity for patients with certain types of cancers to directly consent to being part of building a large data set around that cancer. And then that data set essentially becomes open access for research amongst qualified and sort of identified research projects. So as part of the overall Count Me In effort, we've launched what's called the LMS project, which is the Leiomyosarcoma project. And we are actively recruiting or asking people that may want to participate in the LMS project to provide, not only does it allow people to provide their clinical records, their tissue samples, plasma, as well as additional samples, but we're adding on an add-on to allow people the opportunity to send in preoperative MRI prior to hysterectomy in women that ultimately were found to have a leiomyosarcoma of the uterus when they may have been thought to have a fibroid. And our target goal is to see if we can get up to 100 cases. We think that's actually we think it's doable, but we know it's not going to be easy. We know it's really going to take a really, large effort to make people aware of the opportunity, and we want to support people that want to participate and share their data for research.
Yeah, I think this is, Lisa, we had talked with Corey and Katie, Dr. Painter and Dr. Janeway about Count Me In and the patient engaged. I don't know if that's the right term, but the patient engaged research, the direct patient engagement. And this is just like another prime example of how powerful these data sets can be, and, trying to partner patients with physicians and researchers, and then leveraging the technology to teach the systems to see the things that we can't see with our own eyes to better predict malignancy or benign conditions. That's really amazing. Super, super cool.
The other thing that we're doing in that, just to make one more comment about the MRI project, is just that we are actually, the first pass that we're doing is actually looking at standard MRI features. We anticipate that a second pass will use more complex technology around imaging, but we really wanted our first pass to be accessible. And so the paper that I mentioned used features of imaging that would be on a standard MRI in most environments. So that's what we're hoping to validate, to see if we can come up with a system that helps to validate these risks in a standard way that could be readily accessible, independent of what resource level environment people are in.
Yeah, that's really important. I am in Minnesota now. There's a wide catchment area from which we draw from, and the majority of the patients in the U.S. are treated at smaller centers, or these images are happening there, and you have to sort of build it so that a standard MRI machine and not something that's only available at Mayo Clinic or Dana-Farber can do it. Otherwise, it's useful.
Exactly.
And so I suspect that the things that you're looking at, just for our kind of listeners, is things like we can tell on different sequences if something's bright or dark or things like that.
Yes.
So those are those characteristics that we're looking at to help better help our radiologists determine what's going on in that particular woman's uterus.
Yeah, those are exactly the kinds of features, and also some issues of shape. What shape things are. Do they look like they have smooth edges? Do they look like they have more jagged or infiltrative edges? And how do you put those pieces all together? And we're working really closely with as we talked about, I'm a medical oncologist, but working really closely with people that really spend their careers doing pelvic MRI. So we have a nice collaboration with some of our imaging colleagues as well.
Go ahead, Lisa.
Oh, I was going to say, yeah, and this is so exciting. And I remember one thing that Dr. Painter had said with angiosarcoma is, from having such a rare sarcoma, but then being able to gather this patient information, they were able to see some things that could later on help with treatment, like that some types of angiosarcoma might be more susceptible to immunotherapy and different things like that. But for the patient, I think it's important too that they know that when they sign up, it's not a big burden on them. And so I was just wondering if you could speak to that, like when they sign up, they getting their plasma means giving some blood or maybe a cheek swab, but they don't have to track down their images to send to the project.
No, exactly. No, that's correct. And just exactly. So when people sign up for Count Me In, they or that this would, you know, specifically the LMS project, which works like the other diseases in the area, but is they sign consent, and then they have to provide, and then they provide information around where their materials are, like where their records would be, where their imaging would be, where their samples would be. And then it becomes Count Me In's job to track that down. They may be asked to sign a release form, or because, you know, oftentimes the hospitals will accept the consent form that they sign as part of the project, but sometimes they don't. Sometimes the hospitals want an extra release form just to make sure that they are being the proper stewards of the patient information. But it really does become the responsibility of the project to track down all that information. Yep. And similarly, even though just like you said, even though I talked a lot about MRIs, this project really, that's an add-on. This project really is about sample collection, so tissue collection, plasma collection, to help us also understand the biology, see if we can understand the biology of the tumors such that we can get therapeutic insights as well.
Yeah, well, I have two questions. I'm going to get to the biologic insights. If you're trying for your validation set for the imaging, if you're trying to get 100 cases of uterine, I almost said rhabdomyosarcoma, uterine leiomyosarcoma, based on the numbers that you see kind of across the country, what percentage is 100 cases of newly diagnosed, and like how long do you think this will take to get this validation done?
So there's probably a couple thousand cases a year of leiomyosarcoma, of which that, you know, could up to 50% be uterine. Maybe that's an overestimation, but you know, we're in that ballpark. And then people can be cured of the disease, and people can, even if the disease comes back, people can live with it. So there's likely women that are living, either have had the disease or living with the disease, that have had MRIs done previously. We just need to let them know that this is an opportunity if they so choose to participate.
Yeah, excellent. And then the question to the biologic insight, I think that our conversation with Dr. Painter, I think, has kind of lasted in our, you know, I've heard her speak at multiple different things, and it's always engaging, and it's hard to kind of keep my attention at baseline. So anybody that can do that, you know, they're a good speaker and they have a great story to tell. And it's so fascinating about the biologic insights that they learned about angiosarcoma. So what do we know now about the biologic underpinnings of leiomyosarcoma? What are those unanswered questions that we hope to answer with more tissue from Count Me In?
Yeah, it's a great question. So, you know, we have a pretty good sense from a number of data sets that leiomyosarcoma, we know that leiomyosarcoma doesn't appear to have a single targetable driver, as we had talked about before. And we also know that when you look at the genes in leiomyosarcoma, that there's a couple of genes that are very consistently altered. And those include what's called RB1 and TP53. So very, very frequently those are altered. But the tricky part is we don't yet have a way to exploit that from a therapeutic perspective. Like, we can't use that as a treatment. But we can use it as a way to say, yep, that's very consistent with leiomyosarcoma. But what we also know is that these tumors tend to have what we call some degree of genomic instability. So they sort of have a lot of the chromosomes either have additions or losses, or the chromosomal pattern or the genomic pattern it has quite a bit of chromosomal instability. I don't know how to use a better way to frame it. and it has something else called it. It often tends to have a high copy number alteration. So the genes are just kind of up and down. A lot of what we have in larger data sets, though, are either from primary tumors. So if you look at the TCGA, which is like the national data sets that have looked at the genes in many cancer types, those are primarily primary tumors. So the amount of information we have on metastatic tumors is much less. Also, the amount of information that we have on paired tumors, so the primary plus the metastases, how does it change from when it started to when it spread, is also much less. The other thing is that I'm hoping that we can learn more from the Count Me In project is actually more specific types of leiomyosarcoma. So we talked about uterine, we talked about extremity, we talked about retroperitoneal, but we have very limited data sets that look at the genomics or the underlying biology based on location. And interestingly, because uterine leiomyosarcoma is such a common site of this disease, we also have a real heavy, there's a lot more women that we have samples on than men. And so I also hope that we can kind of start to balance our sample size across a variety of different clinical features, location, gender, et cetera, to see if we can see any differences. Maybe we won't, but maybe there are some subtleties in there.
Yeah. Yeah, I remember, I don't know, it was a couple of CTOSs ago, listening to Dr. Antonescu's talk about like all of the new sarcoma entities as we learn more about their molecular features. And it's like every year we add like, several more sarcomas. And are we going to get to a point in leiomyosarcoma or, fibromyxoid sarcoma where we're broken down by molecular characterization rather than this has a P53 alteration and happens to be in your retroperitoneum. And I think we'll get there to some degree. And projects like this are very important for that, where we're trying to really pool all these really rare people together and then pull them together and then parse them out all at the same time.
Yes, I think so. I think the other thing about the LMS project through Count Me In is that in addition to the tissue, people are given the opportunity to share their clinical data. So they're given the opportunity to share what chemotherapies they've had, how they did, from the records you can pull out, like, how did they do with the chemotherapies? How well did it work? How long did it last? When did they need to switch to something else? And actually having that clinical annotation to match up with the tissue has a potential to be very powerful, because we don't always know, like, why is it that patient X responded so well and patient Y didn't? Like, how could we have known that from the beginning so that we could have done a better job matching treatment, even standard treatments? So this may give us some insights into that as well.
Yeah, I think, it's probably something that I didn't understand as a young physician or a young oncologist either, is that it seems sometimes like when you're kind of outside of a system or you're just kind of going about your life, it seems like, well, why wouldn't physicians know that information? Like, why isn't that clinical annotation there with those samples? And the truth of the matter is that sometimes it just doesn't exist. And it requires these really Herculean efforts and really smart people to put these projects together to get all the information in one place. So it's matched up: patient, clinical annotation, primary tumor, metastatic tumor. But we need these projects to kind of keep pushing that forward, because in the healthcare system and in the EMRs or the electronic medical records, that may or may not always exist. And certainly at any one institution, there's usually not enough power in these rare tumors to do all that study together. So I just say that out loud just to kind of explain why in these rare tumors, in this rare sarcoma world, why people like you are trying to get these efforts forward and get this information in one kind of data clearinghouse to have more power to the discoveries that we can make. So super, super cool stuff. I talk a lot, so I'll let Lisa talk.
No, I was just going to say, I'm so, thank you for making that point. It's so important. And I think also the point that you made about rare tumors, there's so much more. You can learn so much more when you pull things together across multiple places, because, again, as I mentioned before, we know at Dana-Farber, for example, where I happen to practice, like we have a very high referral rate. Like a lot of people come to us because we have a big program. We have a lot of clinical trials. We do a lot of research, but that doesn't necessarily always reflect like how people are doing that choose not to come to a tertiary center. So most of the patients we see will end up having metastatic disease, but that's because they're the people that are looking for, they want to know what's happening that's new for their situation. Whereas patients with localized disease, it might be just doing great. They may never end up in a large center like this. And the cool thing about Count Me In is that because it's an entirely web-based system, people can participate independent of what institution they're at. It's direct to patient participation. So wherever the only limitations are that it's US and Canada. If you're US and Canada and you have leiomyosarcoma and you want to participate, it's awesome because then the opportunity is available.
Yeah, and I think that's such a good point because, I think when you're someone who was diagnosed with cancer, you want to go to the best place or the place that has the best reputation, and I think many people would like to go to Dana-Farber or MD Anderson or these places, but they don't, it's not realistic. And they, so many times they'll get excellent care where they're at, but when you're the one with the cancer, you can look at it very different. And I think, these programs through Count Me In, they allow the patient to be empowered because they're able to do something, to join this community and join this project and really help. And, that is one thing that it might not help for their particular cancer at that point in time, but giving this information will just help to move it forward. And I think with any patient, or in our instance where Wendy and I talk to many parents, it's like even they just want to help to move it forward so the same thing doesn't happen to them or their child, where they go to a doctor and the doctor just tells them how rare it is and that there's not many treatments. So I think what this is, it empowers everybody, and the patients are really making a difference that only they can make. Just like you said, Dr. George, it doesn't matter because if you see a lot of patients at Dana-Farber, because they may be only a certain subset, like these metastatic leiomyosarcomas, and we need information on all of it. And actually, so one of the questions I had on that though was, do the patients, they obviously can sign up and we're going to give the website where they can sign up and everything, but then is there any information shared back to them, or do they get to, are there, for instance, like a Facebook group or anything where they get to get information and communicate, or how does it work? What advantages do they get because they are, sharing such valuable information?
Yeah, that's a really important question. So as part of this, as part of the LMS project, so the Leiomyosarcoma project, as well as a companion part of the osteosarcoma project that Dr. Janeway talked about, those two projects are launched within a grant as part of the National Moonshot effort. And part of that grant, one of the requirements of that grant are actually that we focus on return of results to the participants. So what that means is that for people who choose to participate and choose to send in a sample, one of their tumor samples, that sample will have the genes analyzed. So they'll tell us what genes are there. And then we will be returning some of that information about what we learned by reviewing the genes for their particular case. We actually have decided in the context of this project, we're actually not calling it return of results, we're calling it shared learnings. And the reason is that this is still, parts of this work are still research-based. So we're doing a more in-depth evaluation of the tumor than perhaps we're also still learning how to use and how to use in the clinic. And this is very much a research project. So we are returning as we learn. We want to share those learnings back with the participants because we couldn't be learning without them.
Yeah, I think that's so exciting and important for them, because I think that's where a lot of times when patients who have cancer then share their data and they wonder, well, where does it go? And I know it's supposed to be for this good project, but I don't get anything back. But then But then that is really exciting that they get this information back too. And like you said, it's still being understood. Well, what do all these results mean? Does somebody go over it with them from the Count Me In team?
Yeah, so actually we're working on the template. We're actually finalizing the language and the structure of how that information is going to go back. And we're doing that with we are doing that with patients and families to make sure that we're meeting the needs, and the information can be available primarily for them to review with their care team, as opposed to with the Count Me In team. But I actually think personally, I think that this is something we need to consider. We need to consider how to really optimize the shared learnings. I think we need to consider also as the data, whether it's within this project or other projects, I think as people provide data, I think that people should have the opportunity to know how that data is being used. And I think that there's a lot of efforts that are trying to try to solve that particular issue.
That's great.
Whether
Yeah.
it's in Count Me In or any other project, frankly.
Yeah, and that's such a work in progress, but I think it's so important. Just like you said, it really, another thing that will empower the patient,
Yep.
too.
Definitely.
Yeah, I think you may have to splice this back to the future conversation, Lisa. But I think, one of the things that you said, Dr. George, that just really struck me is, I too work at a referral center, and, my population too is very skewed. And we have this conversation a lot in pediatric oncology of do you need to go to a sarcoma center, or do you need to go to a big center? Can you be treated in your community or at a smaller center? And projects like Count Me In that now are able to access patients that haven't been to those referral centers. When the data set is done, if it shows what we think it's going to show, that, yeah, you're probably just okay to stay with your local oncologist if you have stage 1 completely resected leiomyosarcoma, that information in and of itself is very useful to people, to know that you don't have to spend your 401k to go to Boston. Y'all have an expensive city there. I was just there.
Yes.
So, it's okay to
agree.
get your place, and you can feel reassured about that and know that you're still getting the very best care. And so sometimes our data sets are very skewed because the people that are doing the most research often see the most advanced cases. And so that has been really hard to parse through in a lot of the sarcoma world. And some people feel very strongly on one side versus the other, like, should you go to a sarcoma center or not? But I think that information will be very, very valuable once it's complete, if, particularly if it says what we think it's going to say. But you don't know until you have the data.
That's right. No, I think that that's a really good point. And that's one of the things that is being captured, is where the data are coming from. And it's being done in a way, just as you said, it's not being done to compare one hospital to another hospital, but more to give us the opportunity to look more at high level between community high volume sarcoma, for example, to see if there are any clear patterns or differences based on locations of care. That type of work has been done a fair bit in adult sarcoma in Europe, but the European health systems are just so different than the US health systems in terms of their structure and referral patterns, et cetera. But it will be interesting to get some of that information as well.
Yeah, that's very cool. Wait, Lisa, we're almost at the top of the hour. I have to ask my favorite question, which is always the one where people always sigh at me. But what do you think?
Uh-oh.
One sentence or less. No, just kidding. What do you think is the next thing for leiomyosarcoma? What are you hopeful for? What do you think may be sort of on the edge of something that's coming our way in terms of treatment or discovery?
Yeah, I actually think we're learning a lot about DNA damage and DNA damage vulnerability pathways in leiomyosarcoma. There was a study that was an NCI-based study that suggested that that's an area where we might be able to really make a difference. And then there would be a couple more studies that are coming in follow-up. So I think that what's called HRD and DNA damage repair as an overall theme is an area that really needs to be looked at. The other thing in leiomyosarcoma is that there are small, rare cases of genomic patterns that actually are quite targetable. It's not common, but rarely you'll find someone with a BRCA2 alteration, for example, that clearly can respond to PARP inhibitors. Not all of them, but it's sort of similarly. I've had a couple of patients recently, actually, that have had what's called MSI high. So basically a genomic pattern that's sensitive to immune therapy, for example, which immune therapy generally does not work in leiomyosarcoma. Every once in a while, you'll find someone with one of these patterns. So although the majority of time, we're still searching for what is that vulnerability. What we are seeing is that there are these little subsets of people where a sort of a targeted approach might make a big difference.
Yeah, I think we're all, as we learn more and more about the genomics of all of our tumors that we take care of, sometimes I feel like the more I know, the less I know. But then also, you always have those exceptional responders, that one patient who you found something in, and those are the ones that kind of keep us going, I think. And I hope that in the future we have better prediction algorithms and faster turnarounds and all of the things. And I think we're getting there. I feel fortunate. I'm not super old, but I feel fortunate to have started practicing oncology, focusing on sarcomas in a time where the technology has really, it's at a place where we can do this sort of study, because I imagine in the early and late 90s, it was pretty a blank canvas without a lot of guidance. And so I feel fortunate that I am the age that I am.
Yeah, no, me too. It's an amazing time in oncology. I mean, things have really changed a lot in terms of the tools we have to try to understand the diseases, and to some extent the therapies we have. We certainly need to do so much more, but I think you're right. It gives us hope that there are opportunities to approach these really challenging diseases, but to approach them with knowledge and with passion, and with really, working hard together with the patient communities to help us try to bring better treatments forward.
Absolutely. Lisa?
I was going to say thank you. I feel like that's a perfect thing to end on. And yeah, we will definitely give the link to patients. If they also Google, they could find it. It's the Count Me In Leiomyosarcoma project. But we'll give links to that too. And when we publish this up on Twitter and Facebook, so they can find it as well. And like you said, we are hoping that a lot of patients will be willing to share, because it will make such a difference, I know, in this sarcoma. And we really appreciate you coming on the show and giving us your time and really letting the community know about Count Me In.
Great. Thanks for having me. It was really fun.
Thank you.
Thanks.
Thank you.